Have you ever wondered why the cost of the same prescription medication can be so drastically different from plan to plan and pharmacy to pharmacy? Why is it that sometimes when you get a prescription filled, it is actually cheaper to use a GoodRx coupon and pay cash than it is to use your own health insurance plan? And because these type of situations happen all the time, when you go on Medicare, is it really necessary to enroll into a Part D prescription drug plan? And if you do enroll, how do you even know you're on the right plan? It is these questions and many more that I'll be answering in this video. I thought it would be helpful to begin this video by making sure that all of us have a good understanding as to the process of getting medications that you and I take. It's not as simple as someone making the med and then we're able to go to the manufacturer and get that medication. It doesn't work that way. There's actually this entire drug supply chain. And this poses some problems and also adds some cost to the price of medications, of course, for us. But let's talk about this. So we begin here, the manufacturer, obviously. Someone's making the meds, and they're making brand names, sometimes just generic, sometimes both. So this is going to be your Pfizer, Eli Lilly, Johnson & Johnson, Merck, these kind of companies, of course, that are making medications. Now, they do some direct selling in certain situations, but a lot of the meds today are actually sold to a wholesaler. These wholesalers are buying these in bulk and then selling them to pharmacies and hospitals and to the government. And so this would be companies like Cardinal Health or McKesson, a variety of companies, of course. So they're making them and then they're helping them move into the market. But we also have another player in this, and that is the pharmacy benefit manager. And they really do play a huge role. Now, they're actually certainly not dispensing any medications, but they're the one that's managing the insurance behind this and to make sure that the medications are in a formulary. So again, huge part in this whole process. So they're help process claims, make sure that insurance company is being paid. And they're also the one that decides on what medications are in what tier, and will it be a preferred medication or a non-preferred? Will it be a specialty medication? So the whole point is they're managing the movement of these medications. So what happens is this. They actually get rebates, and that's how they make their money. And it's the manufacturer that actually gives them the rebates, because the manufacturer gives the rebates. So these PBMs will actually make sure the meds that they're making are going to be in the formulary. And so they get paid to make that all happen. But the point is they're going to have to make money somehow, but it's typically through rebates. And those rebates, oftentimes they don't pass that full rebate on down the chain. They keep some of that, of course, as profit. But again, very instrumental part. So the way to look at this, they're making the meds, they're moving the meds, the wholesalers are, and they're really managing this entire process. All right, so then what happens is in the present system, we have then a couple of different ways which we will buy our medications. So a patient could use a discount platform. Now, this discount platform actually has a relationship with the PBM. So the discount platform would be your GoodRx, your single care. And so again, they don't touch meds, but they're more marketing the meds and offering people a discount to get meds through their system, so that then this PBM is going to pay them a flat fee. All right, so again, a lot of meds happen this way today, discount platform. Another way is just directly to a pharmacy. And so what happens is the pharmacy is also paid by the PBM. And so this pharmacy could be a CVS or a Walgreens or Walmart or Costco, a variety of places. Some of the pharmacies will be in network, some are out of network. But again, they're going to be dispensing medications based upon what that insurance company is going to cover and not cover. And so the whole point is many, of course, are just retail pharmacies where people are going to get their medications. And then we have Medicare, and we also have Medicaid. So now we're talking about the government. And they also are helped by the PBMs, because Medicare plans, Part D plans, they have to have formularies. Meds are going to cover and not cover, and different specialty meds and those types of things. So again, everyone is looking to the PBM. Of course, eventually, then the patient can look to the pharmacy, could look to a GoodRx coupon if it's going to save money, or of course, if you're on a Part D plan, then you're of course going in this particular direction. All right. So my whole point in sharing this with you is this is the flow that goes through, and of course, everyone that's touching this wants to make some money. And what does that do? That that kind of drives up the cost of our medications. Now I want to show you a second way in which meds are dispensed today, and that's through Mark Cuban's group. And he's called the Disruptor. And the reason for that he's disrupted this whole system is, again, the manufacturers are still making the same meds, and wholesalers are still buying those. But what Mark Cuban and his company did is they eliminated this. No PBMs involved in his system. He is dealing directly with the manufacturer and the wholesaler and making these meds then available directly to the consumer, of course, online. His company is called Cost Plus Drug Company. By the way, I'm not promoting anything here today. I'm just simply educating you as to how the system works. But this is what Cuban has done. So they're gone. So no ability for them to make markup and do rebates and all that and add really to the cost of this. And so what he does to get the medication to the patient, because his whole goal was to do it at a lower cost, is this. They actually are very transparent about the cost of the medication. Let's say a medication, he would buy it for $10. Okay, so what he does is they mark it up 15%. So it's a flat markup. So in this example, if it costs Cuban's group $10, he's going to add $1.50 to it. And then they're going to have a dispensing fee, and that is $3 per prescription. So we got $3 added on here. And then there's going to be shipping. Now, the way his shipping works is it's $5 per order. So if you've got 5 prescriptions, that would end up being $1 a prescription. It's $5 per order. If it was just one prescription, it would be $5. But the whole point is, this is how he prices everything. Very simple, a simple markup, very transparent. And so that's why they're calling him the Great Disruptor. And again, primarily generics, though they are starting to carry different brand names as well. But again, these are the two ways in which we are going to get our hands on the medications that we need. All right, that brings us then to Medicare drug coverage. Let me explain exactly how this system works. Most of you watching this know that Medicare has different parts, A, B, C, and D, and E is not often talked about, but those would be Medigap policies. So Part A of Medicare is the inpatient side of Medicare. This is hospital, skilled nursing facility. And Part A certainly pays medications. When people are in the hospital, skilled nursing, they're certainly going to need meds. And so A will cover those. Part B is going to be your outpatient side of Medicare. So someone has outpatient surgery, no doubt some anesthesia during that outpatient procedure, or pain medications to follow. But Part B also pays meds that would be professionally administered. So if someone goes in and they're taking a shot, let's say they're doing chemotherapy, that's on an outpatient basis. B is going to cover that expense. If someone has a medication that has to be professionally administered, such as Prolia for osteoporosis, again, we go to a clinic for that, a doctor's office, and Part B is going to pay that. And so what happens is, on the B side of Medicare, when they cover a medication under B, then Medicare pays 80%, but you as the patient would be responsible for 20%, all right? And so the whole point is A and B pays meds, but here's what happens. Sometimes people will get a Medigap policy. Today, the top plans are the Plan F, the Plan G, and the Plan N. And all those plans are going to cover that 20% out-of-pocket expense that the patient would be responsible for. So one of the reasons people buy Medigap policies is, again, to get those gaps covered, and that would be 20% on that. And then we have Part C plans. Now, Part C plans are called Advantage plans. They're also called replacement plans. And so what they do is they're actually going to match this outpatient coverage under B and the inpatient under A. They match that. So that means over here, they're going to cover the inpatient, but over here, that remaining balance that someone would have where the Advantage plan pays, because a lot of times they're going to pay also 80-20, so you'd be responsible to pay for that out of your pocket. And again, that varies. Sometimes it's only 10%, but the point is Advantage plans are structured where you have co-pays and you have co-insurance, and you would have that out-of-pocket responsibility placed upon you. And then we have Part D plans. Now, here's the distinction between D and A and B. A and B are professionally administered medications. Part D plans are going to be our self-administered medications. So this would be your cholesterol meds, your high blood pressure, your insulin, those kinds of things are going to be covered by Part D plans. Also, I want to mention this, Part B does cover certain immunizations, vaccinations, and so will Part D. So both of those cover those at no cost, depending upon which type of immunization you're going to need will determine who pays them, but those are the two government systems that will. And so the point is, when we self-administer medications, if I decide to be an A and B and I get a Medigap policy, what happens is our Part D plan is called standalone. It's a standalone Part D plan. That means it is separate from my Medigap policy. In fact, I could have one company providing my Medigap, and I could have a whole different company providing my standalone prescription drug plan. And of course, these are the plans that change on an annual basis, but you picked that out if you have a Medigap policy. Now, if you have a C plan, what happens is the majority of them actually will include a Part D plan as part of their services. So we call these MAPDs. Medicare Advantage, that's taking care of my in and outpatient services, and the prescription drug plan that is included as part of, again, that got coverage. All right, now I want to clarify something. There are some people that don't have to have a Part D plan. If you get your medications through the VA, or you're retired military and have TRICARE, or you're still working and you have an employer-provided plan, or you're retired from the federal government, you have what's called the FEHB. All those are different drug plans are considered credible. And so if someone has those options, they don't have to have a Part D plan. If not, they of course need to have a Part D plan. I'll explain the reasons for that next. All right, so this is the last thing I'm going to discuss with you. This is my last slide, but I hope you'll stay with me because this is critical. I've been in this business now 17 years, and there are people who will say to me, well, Marvin, why do I need a Part D plan? I don't take any medications, or I know I can go to pharmacy and pay cash for them or use a coupon. Well, folks, what happens in that scenario is you're just looking at the medications that you're taking right now. And I hope you never need any additional medications beyond what you're taking, but things can change very quickly. And as we age, there's a high probability of that. All right, so there really truly are 4 reasons why people need a Part D plan once they retire and go on Medicare, unless, of course, they have VA, TRICARE, or FEHB. Reason number 1 is because brand name drugs, they're very expensive. Now, 90% of all meds prescribed are actually generics, but 10% of them are brand name medications, and they're very expensive. Lately, I've had several cases where people needed Stelara, and I had one gentleman was on a medication for Stelara. His dosage and frequency retail cost $13,500. I had a lady the other day whose dosage and frequency for the same medication was over $30,000 on a monthly basis. Okay, so you may not be on something like that now, but things could change very, very quickly. And so because brand name medications are so expensive, you need a Part D plan. And again, Part D plans can be very low cost. So we have some on the market right now that are less than $5 a month. But if you need an expensive medication, you'll be very grateful that you have one. Okay, so we don't just get a Part D plan for what we're taking now, because those could be cheap generics or no meds. It's in case we needed a brand name medication. And this is why. Because all Part D plans today, and just so you know, this began in January 1 of 2025, this new rule took effect. And that is that there is now a max out-of-pocket for you. The most you'd ever have to spend on any Part D plan, whether that's standalone or whether it's embedded within the Advantage plan. And that Part D cap right now, in this year, I'm shooting this video 2025 September, but that max out-of-pocket is going to go up a little bit, not much. So in 2026, they're going to raise the max out-of-pocket to $2,100. Okay, so not much of an increase. So the point is, if I'm up here on a brand name medication and it costs $13,000 a month or $33,000 a month, or self-administered chemotherapy pills right now are somewhere between $5,000 to $7,000 a month, you will not pay that. Why? Because once you have spent out of pocket your $2,000, you are done for the rest of the year. Now keep in mind that medication cap includes only meds that are in the formulary. And that's why formulary is the most important part of any drug plan decision we make. We want to make sure the meds are covered by the plan, because then they will fall underneath that $2,000 cap. Now, that $2,000 does not include the premium you pay for the plan, but it includes the deductibles, the co-pays, the co-insurance, whatever you have to pay, no more than $2,000. Now, sometimes people, that $2,000 is due the very first fill. And if they don't have it, what happens? The government will actually take that $2,000 and they will spread that out over the remaining months left within the year. They call it a smoothing. So you can actually, spread that out and make it a little bit more possible for to afford that. Okay, you don't save any money by enrolling in that plan, but you do get to spread out those payments. Those are called Medicare prescription payment plans, and every Part D plan will give you the possibility of enrolling into that. Okay, so that's why we do it. We love the max out of pocket. All right, now thirdly, I want to talk about this. Another reason you do it is because if you don't take a Part D plan when you are 65 and retired, or when you do retire later in life, if you don't take one when you're first eligible to do so, again, at retirement, then what happens is they're going to start assessing penalties. And so the way it works is this: for every month you go without a Part D plan, there's a 1% penalty, and that 1% penalty is based upon the national average drug plan. And again, I'm just going to give you kind of a rough estimate here. Right now, it's about $35. So 1% of $35 is what? 35 cents. Okay, and so that would be a month. And so let's just say that I go without a drug plan for a full year. When I was eligible, I could have had one, I didn't take one, and so now they're going to take that 35 cents times 12, and that's going to be $4.20 penalty. And so when you do decide to enroll into a drug plan, they're going to add that $4.20 penalty to your drug plan every single month for the rest of your life. See what happens? And so again, these penalties can begin to add up. I've dealt with people that didn't have a drug plan for 5 years, got sick, needed one. So you take that, 5 times 4, $20, $21, and it was added to their Part D plan for the rest of their life. So those penalties, they're not huge, but they're lifetime, and they will begin to add up. And so that's why I encourage people, get a plan when you first retire. Now also, there's future risk. And what I mean by that? Well, let's say someone does go without a drug plan. They just don't enroll in one. Meds are cheap, they don't take any meds, don't want to spend the money for a drug plan, and then what happens is then they have an illness, some kind of a sickness where they need a real expensive medication. Well, what happens is you just can't pick up a drug plan when you want. You can only pick up a drug plan if you didn't take one when you initially were eligible. If you don't, and you want one later, the only time you can add a drug plan, folks, is October 15th through December 7th, and that is it. And that drug plan you picked out will go into effect January 1, right, of the next year. So whatever that is going to be. So the point is, not only are you going to be penalized, but now there's this risk. So let's say that I don't take a drug plan and I have some kind of a serious illness, something happens, and I need a medication in March, and I have no drug plan. Well, you just can't add a drug plan. Now you're going to have to wait until later in the year, October 15th, December 7th, and add that plan then will go effect January 1. So you need an expensive med in March, but you don't have coverage now until January 1 the next year. And so that's what I'm saying, there's future risk involved. You can only add drug plans at this particular time of the year, all right? And so those are the 4 reasons. So we encourage everyone, get a drug plan. Again, you can just get a very simple drug plan, one that has a decent formulary, one that has a very low cost, because at least then you have something, and then if you need to add something the following year, we can always change drug plans and improve our position during the annual enrollment period. All right, so that explains how drug plans work with Medicare and why it is that I think they're so essential.